Well, what a tough act to follow. That's very scary, Bruno. I'm just going to talk a little bit about mixed reality and some of my experience with mixed reality. It doesn't seem to be advancing. Bruno, can you get artificial intelligence to advance my slide? There we go. Okay. So really over the next 10 minutes, I'm going to talk a little bit about mixed reality navigation and explain to you what that is. And I'm going to go through two studies that we did. The first study was to compare just freehand navigation on the glenoid, surgeon-assisted, I guess we'd call it, patient-specific instrumentation and MR navigation. And then another study that we did validating the MR navigation in cadavers. And I'm going to tell you how I use this in my practice today. So what is surgical navigation? Well, surgical navigation is any technique that allows a surgeon to precisely and accurately track instruments and the patient's anatomy to kind of replicate or execute on a preoperative plan. And right now, there's really, I would say, two more popular forms of navigation. The first is optical navigation, which really Exactech has done a wonderful job with, and they really lead the market with respect to this. And then new is mixed reality navigation, which you can see a lot of companies out there. I think Medacta is out there, Stryker is utilizing this. So this may be the future because it may be much more compact. So what is mixed reality navigation? It's essentially the use of these holograms, and these holograms are then registered to the instruments and the patient's anatomy, and these holograms allow the surgeon to then execute with some degree of precision and accuracy the preoperative plan. And so this is the first mixed reality navigation case that I did on the right here, and you can see that as I'm operating, I have this hologram up that then allows me to determine, I can preoperatively plan where I want to place my base plate, and then I'm going to insert my guide pin. Sorry. So what do we need to do? What do we need to have to do mixed reality navigation? Well, you need a headset. There's several different headsets out there. The headset that we partnered with is with Microsoft, so this is a HoloLens 2. You then need to register the preoperative plan to the patient's anatomy. So this is a stylus. This is the guide pin, essentially the pin inserter, which is also guided, and then you need to have a coracoid clamp right now. The unique thing about mixed reality navigation in the very near future, this will all be visually done, meaning that you don't actually have to place a tracker on the patient. The HoloLens itself has essentially, simplistically put, is almost like a laser scanner, and so you can actually scan the patient's anatomy through the lens and not have to actually put a tracker on. And so that's certainly the future without the use of trackers. And so once you have the clamp on, you're going to register the patient's anatomy to the preoperative plan, and then you're going to go ahead and navigate in your guide pin. So this is the first study we did. As I mentioned, we compared these three techniques. So what our goal was to compare navigation to patient-specific instrumentation to the surgeon's freehand technique. In our methods where we had 15 severely eroded glenoids, and what we did is we made preoperative plans and then printed each one in triplicate so that each patient's deformity would get all three techniques, and then we randomized them. So this is the traditional software planning, which is essentially what I used to do, where I look at a preoperative plan and I try to replicate that at the time of surgery with no real guidance, but just using a traditional guide. And then mixed reality navigation, so we're going to go ahead and do that. So what we're doing here is there you can see the guide pin inserter, the cube. This is what the surgeon sees through the headset. So what we're trying to do right now is position the guide pin, and once you've positioned the entry point, you can go ahead and look at the version and inclination. So ideally you want it as close to 0 as possible, but if you choose to put it in 10 degrees retroverted, you can choose to do that. So here I'm going to go for a 0, 0 to try to get to replicate that preoperative plan as I'm moving through. And the third technique we tested was a very traditional patient-specific instrumentation technique. And the outcome variables that we wanted to look at inclination, version, entry point, and they wanted to have a sort of a composite score, so we call this total global error. And these are our results. So when you look at the inclination error, TSP is the traditional software planning. We find that mixed reality navigation and PSI were both better than traditional software planning, which kind of makes sense. These are both navigated type techniques. Looked at version error, once again, very similar, that both PSI and MR-Nav were better than traditional software planning. And the total global error was also very similar in that the navigated techniques seemed to be better. So our conclusions for study number one is that MR navigation and PSI are both significantly better than a surgeon's freehand technique, and that makes sense. And we also showed that there's actually no significant differences between the two techniques, meaning MR nav and PSI. The only advantage of MR navigation in this scenario is that it's instantaneous, means that you can do your preoperative plan and then take it to the operating room and navigate it. Versus a patient-specific guide, typically you have to wait 4 to 6 weeks for the guide to be 3D printed and then mailed to you. So there is some advantage to MR navigation here. Now, study number two was a cadaveric study. This was done by my friend Joaquin Sanchez-Sotelo. We had Mike Freehill, Jean Chaoui, Philippe Collin, J.P. Warner, Gilles Walsh, and myself did this study. And our objective was really to determine the reliability of MR navigation for guide pin insertion. So these were our methods. We had 7 surgeons, 14 specimens bilateral. We looked at both TSA and RSA, and we used MR navigation for all of them, and our outcomes were very similar to the first study. We wanted to look at inclination, version, and entry point. And these were our results. When we looked overall at the entry point, we were able to have a mean deviation of 1.7 millimeters, so under 2 millimeters. We looked at version and inclination, both under 2 degrees. So our conclusions for study number two is that MR navigation allowed surgeons to insert a guide pin within 2 millimeters of accuracy and within 2 degrees of version and inclination, so a very powerful tool. So the question is, how do I use MR navigation now in my practice? Well, we're really much in the early days. The first MR navigation case was done in December, and so I've only recently started to use this technique, and I find right now I'm using it for probably the most difficult and deformed glenoid. So it's not an everyday technique for me. Just as Alex said earlier on, you still have to be a surgeon. You still have to have common sense and realize when something is not right. So for me, it's really for those complex cases. Is it the future for all the cases? I don't know, and I guess the future will tell us. So maybe I can ask Bruno to ask your AI machine, will MR navigation be the future for all cases? I don't know. So the other thing to realize is it's a very competitive landscape out there. If you look at, we have mixed reality navigation, there's optical navigation. Ruth talked about robotics. I think robotics is certainly the future also. We still have PSI guides, and now we also have patient-matched implants. Where are we going to go in 5 or 10 years? What technology is going to be superior? I think the only way to tell is actually probably to ask AI or just live through this process and see what comes to the top. So in summary, I think MR navigation is effective, it's precise, it's accurate, we've shown it's safe. I think we spent a lot of time on the glenoid, and I think the next big mystery for me is the humerus. So robotics, MR navigation, and optical navigation on the humerus is certainly the next step. Thank you.